Hi again, everybody. I hope you've enjoyed some lunch. I know those chocolate strawberries are quite addictive, but I invite you to shovel them in your mouth and then come back to your seats here so we can carry on with this afternoon's programming. This is going to be a quick but really interesting session. How can innovation in health workforce regulation help ensure the highest quality care while also improving the international mobility needed to meet changing demand and evolving health challenges? In this session, we're going to hear from two speakers, and we're going to highlight regulatory best practices and governance innovation. So will you please invite my speakers up? Let me invite them to the stage to join us. Joining us is Dr. Gregory Ganda, who's the Minister for Health for Kisumu County in Kenya, which is a region of 3 million people in the west of the country. He's also a practicing obstetrician and gynecological oncologist at one of the country's largest public teaching and referral hospitals. And Emily Sheldon is the CEO and co-founder of the African Health Innovation Center, which is a Ghana-based NGO focused on innovation and entrepreneurship to improve health outcomes. I hope I didn't scare you off then. You're just moving. Okay, fine, great. No, I appreciate that. Speakers, thank you so much for joining us this afternoon. I want to start off just with a bit of level setting, first of all. What is the problem we're seeking to address here? You know, when you look at the current landscape of health workforce regulation, how would you describe it where you're working and based on your particular perspectives? You should have a microphone by the side of your, and it's on already. Got one? Yeah, it's on. Do you want to go first, Dr. Ganda?
All right, fine, thank you. I think there are several things to do with the current regulations, but more to do with the number of years that have passed since we started doing medicine. But the first thing about them is that we have fragmented regulations, fragmented in terms of countries, in terms of the landscape. If you come to more developed countries, you have very regulated. For example, the medical practice in the US is very regulated. There's a lot of input on CPDs and the quality of care that you're offering to get your license. But when you go lower down, then that becomes different. Probably it's about number of hours you've worked or just paying the fee and you get your license. Then you come down to where we work. When you're talking about the cadres, you find the cadres have different regulations. In my country, for example, doctors are very well regulated. They have a board and all that kind of thing. But then you have other cadres who are not well regulated. You have community health workers who we recently started to regulate, but they don't get an annual license. Then you have people like traditional practitioners. They're very important, by the way, in the system. You go to places like India, you cannot just practice. The traditional medicine is actually ingrained, and some of the medicines that they use are patented. Now, these things cause a lot of problems. Recently, I was watching TV when a traditional birth attendant gave a mother some medicine. There's some medicine we usually give some herb to give contractions, and they use it. We used to use it traditionally for that you deliver. But she gave this mother this herb, and the mother had an obstructed labor, and she ruptured, and she died. Now, if that happened to a doctor, because you gave oxytocin, there's a regulation, you'll go to court. But because you are not regulated, you can get away with it. I gave this, and it didn't work, and nothing happens. So that gives a problem, because then it is not fair in terms of who is being regulated. The second thing is about adaptation. We don't adopt. The current ones are very slow in adopting. We have telemedicine right now. If you are in America, I don't have a practicing license in America, but you can call me from Kenya, and I'll give you my consultation and tell you what to do. But that's not regulated. So there is many other things. Focus on inputs. Did you do the CPD points? How many years have you practiced? Tick the box, then that's okay. But not outcomes. And if you look at what we're trying to do in our country, we are looking at what is it that the outcomes. From the community health worker, you're looking at outcomes and outputs. But the other people, you're just looking at inputs. So those kind of problems cause a problem with the regulations nationally and in the countries.
Fantastic. Emily, from your perspective, you partner with other organizations in several countries in West Africa and Sub-Saharan Africa. What's the biggest challenge that you see in terms of health workforce regulation?
You know, I think when we're looking at health workforce regulation, we have questions about what regulations are in place, but also how are those regulations being communicated? How are those regulations actually implemented? And from an innovation perspective, we think a lot about, are those the regulations we need both now, but also in the future? One of the really exciting things that I think has been happening as part of this big, challenging shift that we're experiencing in development and in global health right now is that last month, in August, a group of leaders from various African countries came together in Accra to have this African Health Sovereignty Summit, where they were looking at how do we lead with African sovereignty in health conversations now and in the future. And one of the biggest conversations that was happening was about, creating sovereign systems like producing pharmaceuticals within the continent, building diagnostics within the continent. And so I think it's absolutely essential that we're looking at how regulations are happening on the ground right now, but also we need to be forward thinking about if we're developing entire new job streams, if we're looking at new tools and products and services, how are we going to be regulating in the future and in the emerging digital economy as well?
So what do you think are some of the urgent or easy fixes?
Well, I think there's a lot that we can do, even though it feels really overwhelming. And I think one of the biggest areas we can come together is for governments to be working directly with local innovators, local entrepreneurs, and local intermediaries to be able to talk about what is coming in the future and how do we regulate for that appropriately. In Ghana, we have a really exciting project right now that the government is leading with Grand Challenges Canada, with AMP Health, and with a few others called the Ghana Country Innovation Platform. And they put out a call to innovators and entrepreneurs to give ideas that would improve health, but had to be implemented in collaboration with the government. And they have 8 projects that are moving forward, and a couple of them focus on health workforce. There's a project with the Pediatric Society of Ghana that's looking at how do we train frontline health workers, but they're also building out a digital blackboard where they can monitor labor cases so that they can be more easily transferred from lower level facilities to more advanced acute care facilities. We see another project that focuses, it's called Moving Health. They're fantastic, and they focus on emergency transport and also on mobile medical care. Those are both being implemented in Upper East and Upper West regions of Ghana. So if we better know where people need to be transferred, and we have the emergency transportation vehicles to finally achieve that, the question becomes, how are we regulating that transport process? What diagnostics are available? How are we regulating the data that is involved and storing the data that's involved in having all of those innovations? And if we're able to task shift to other health workers, how are we making sure that all of those roles are regulated at the appropriate level in implementation, so we don't have somebody giving an incorrect medication without a level of accountability?
Is that the most urgent fix or the easy fix?
I think it's both at the same time. I mean, I think it is easier than we imagine to work with organizations that are already on the ground creating change. So often governments or aid organizations come in with their own level of expertise, but we have people who are on the ground ready to engage in that work right now. I think when we talk about urgency, what we really also need to be looking at is transparency and regulation. So we talk a lot about, are we having the appropriate regulations, but do health workers know what regulations govern them? We facilitate workshops everywhere from Ghana to Malawi to Kenya, where we sit down as part of government transparency conversations, and health workers say, I don't know what I'm allowed to do in my facility day to day. And how we're communicating regulations, approvals, and abilities is really important. We're working on something called the Pathways Project, which is really exciting, where we're actually trying to map in a really easy to follow format health regulations that exist so that entrepreneurs engage, but also health workers understand how to move through that process in a safe, constructive way.
Okay, so the education is the urgent fix, but the standardization, the consistency in who does what is the easy fix that results. Okay, super interesting. Dr. Ganda, what about you? What do you think? You talked about the very dramatic consequences of unregulated healthcare workers on the ground in Kisumu County and also elsewhere in Kenya. People can die because they're giving medication that they shouldn't be. For example, what are the urgent and easy fixes that you see in how health workforce is regulated?
Thank you. I think the world is moving towards digitization, and I think digitization has a very key role to play in how regulation of health workers will be. First, I think you would need a register. Kenya is trying to create a transparent register, which is publicly available, so that when you say you're a nurse, I could actually check up and say, is this person really a nurse? And that kind of register should be adopted so that when you get your licensing, then you appear in that register. But if you didn't get your license for this year, then you are not in that register. That way, the population can start learning who is what, so that when you say you are a community health worker, then we know you are actually a community health worker. We have a big problem with even community health workers moving in some urban places because you come with a card to say that you're so-and-so, but who knows, you might not be so-and-so. You might not know what you're doing. So that becomes a very important thing. The second thing is getting regulations that are outcome-based and not input-based, so that when you are practicing, once we digitize, we already know how many clients are used. For example, if you're a surgery, how many clients, what is your success rate in terms of orthopedics? How many patients end up walking? What's your infection rate? And all that, so that the outcomes actually determine whether you're going to be licensed or not. We have practiced this with the community health workers. The community health workers are our new people on the block, and so there's a lot of experiment we are doing with them because we always totally digitize them, and we know what we are doing, and we have told them this is what you're expected to do. You're supposed to visit this mother, how often, you're supposed to do what within 24 hours, you're supposed to, and you can check digitally whether this person has been able doing what you're saying. And so if you are not following these regulations that we've given you, then you're off the register. So some of these things actually make a lot of sense. And for you to move across cadres, you just talked about the issue of task shifting. How do we task shift in a data-driven, for example, in Tanzania, nurses do cesarean sections, all right? So in Kenya, nurses don't do cesarean sections. So it is an adaptation. Tanzania didn't have enough doctors to send to the peripheries, but they needed somebody to do a cesarean section. So they decided, why not have the nurses do cesarean section? But then, how do we have this regulation which adopts? In Kenya, we have a big problem because we decided this cesarean section can only be done by a doctor. And so we said, why don't you train clinical officers to do the same thing? But then because the regulations don't have the clinical officer, we say, no, you can't do. And I've had very bad experiences. Sometimes the doctor is not available, but the clinical officer who is there has been trained. He has experience. He can be able to perform. But then you have regulations which are strict and not mobile. So we must be able to have regulations which adopt with the things. COVID-19 taught us many things. At one point, you're saying only anesthetist can intubate somebody. But when you have COVID, then everybody must be able to intubate because it becomes an emergency. So how do we adopt? How do we have regulations which adopt to current happenings in the country or in the area? Thank you.
Okay, I think we're just getting into our stride, but we only have a couple of minutes left. So I want you to give me an example of something that you've seen, some innovation in regulation that you've seen that you think has worked or not worked. I'd love to know kind of why or why not. Either of you can go first.
I think as we think a lot about the digital future and how AI, data, and the digital world is embracing and becoming involved in healthcare, we also have to think about what regulations exist. I've been talking to entrepreneurs and innovators, financiers for a long time, and I always tell them, the ideas are here, the skills are here, the talent is here, but where is that data going to be stored? How do we know that it's available when the power goes out? And how do we make sure that it's protected? The Ghana Nursing and Midwifery Association actually just came out earlier this year with new digital health curriculum for nurses and midwives as they are being trained in Ghana. And to me, this is such an incredible first step to say, we know the expectations of healthcare workers are changing. We're going to get in on the ground floor and make sure that the next round of our health workforce is ready to go. The question is, are we simultaneously developing new health regulations that will be matched with that new curriculum for the next wave of health workers? And we're even looking at how cybersecurity and data storage is included in that curriculum training. So if we have acknowledged that it's coming, if we're training the next round of the workforce, we also need to make sure that our regulations are matching that new level of education.
Very interesting. And also it's interesting because it reminds us that innovation doesn't necessarily need to be about technology as well.
Absolutely.
Dr. Ganda, we have very little time left. What's a good example that you can share that's worked or hasn't worked?
Thank you. I think I'll talk about something that has worked. I'd call it a sandbox, a regulation sandbox. You know, something that allows you to be able to test. And I'll give you two examples. One, LEAP. When you're doing cervical cancer screening and you have a precancerous lesion, there's a procedure to cut off part of that cervix, and typically done by doctors only. And we decided, why don't nurses do this? But we created some small regulation to allow a group of nurses to be able to do, so that we could see there's the outcome change between doctors and nurses. In that particular sense, we found that actually the nurses were hesitant to cut off, and so the repeat procedures were more, and we said, no, they should not be able to do this. But then looking at community health workers, which I love talking about, we thought that community health workers can test for diabetes and hypertension in the community. And we said, okay, fine, why don't we allow this group to be able to do it and to test the outcomes? And when they went, we discovered that they actually can do a random blood sugar. If they are mentored well, some of them became so good and they could do the follow-ups. They could take blood pressure, initially having problems, but with mentorship, they were able to do. And so we rolled that out in the whole county. And actually, the country has now adopted this to be able to allow community health workers to test for blood pressure and to test for blood sugar in the community. So these sandboxes are actually very important in the regulations so that they allow innovation as things move on. Thank you.
Love that. Okay. We're out of time, speakers. This was fascinating. I felt we were just getting going, just scratched the surface, but thank you so much for sharing your experience and your wisdom as well. Give our panelists a round of applause. Thank you.